Hello everyone, welcome back. In continuation with our series of lectures in rheumatology, today we'll be looking at a very basic topic which is approach to arthritis. Okay, so unless you understand this basic approach to arthritis, everything else will be a little more difficult to understand. Okay, so let's get our basics right. So whenever we speak about arthritis in rheumatology, we have to know whether the joint pain that is occurring is basically from the joint itself or is it from the surrounding structures, right? So we have to know if there is evidence of articular involvement, which is joint involvement, or periarticular involvement, which is tendon or bursa involvement, right? So tendinitis and bursitis can also cause pain, which is similar to an arthritis. So if there is tendon or bursa involvement, then it becomes a part of orthopedic management, right? So we'll have to definitely know whether this is an articular pain or a periarticular pain. So what are the periarticular structures? It is a tendon or a bursitis. Okay. So let us understand first. So how will you differentiate if this is a periarticular pain or an articular pain? So always remember that articular pain is usually a diffuse type of pain and it is present throughout the particular joint. Right, so the entire joint will be paining and it is a diffuse type of pain. But when you look at a periarticular pain, the pain will be localized. Right, so it will be localized to the particular attachment of the tendon or to that particular bursa. So very localized patient will be able to point out exactly where the pain is. Okay, so when you look at the articular pain, when we speak about the location, it is present exactly at the joint. But a periarticular pain may be away from the joint. Okay. Now when you look at the aggravating factors for the pain, the periarticular pain is more so in active movements. What do you mean by active movements? Movement by the patient against gravity. So periarticular pain will be more so when the movement is against the gravity. Articular pain will be present during both active and passive movements. Okay. Additionally, if there is joint inflammation or joint involvement, you may find evidence of crepitations, you may find evidence of joint deformities, specifically when we speak about inflammatory arthritis, right? So the first step whenever a patient presents to you with joint pain is to identify whether there is evidence of articular involvement or a periarticular involvement, so that we'll know in which direction we are going towards. Then, secondly, whenever we speak about joint involvement, especially under the umbrella of rheumatology, we will have to know whether we are dealing with an inflammatory arthritis, right? So this inflammatory arthritis, there are certain very specific features to a joint pain to call it an inflammatory arthritis, and this is the basic knowledge that we should be knowing, right? So first is symptoms. What are the symptoms of an inflammatory arthritis? That means you are thinking of probably a rheumatoid arthritis or a spondyloarthropathy or maybe a crystal arthropathy. So when do you think of all this vis-a-vis probably a traumatic arthropathy, right? So how will you differentiate between the two? So inflammatory arthritis has certain characteristic features. The joint pains predominantly have a early morning stiffness. Okay, so early morning stiffness is a very, very important point that you will have to ask for in the history. And this stiffness lasts for more than 35 to 45 minutes. Okay, very, very important point. These joint pains are usually lasting for more than 35 to 45 minutes and you have an early morning stiffness, right? And rest increases the pain whereas activity decreases the pain. Okay, so joint stiffness lasting for more than 35 to 45 minutes, increase with rest, decrease with activity is a characteristic feature for inflammatory joint pain. Okay, and this inflammatory joint pain will be associated with swelling of the joints. Okay. Secondly, when we look at the laboratory findings, there will be raised inflammatory markers. So what are the raised inflammatory markers? There will be evidence of elevated ESR, elevated CRP. which is your C-reactive protein. So both elevated inflammatory markers ESR and CRP may be the laboratory findings which can be seen. Then on the X-ray, if you are looking at an inflammatory arthritis, you may find evidence of erosions, bony erosions on the X-ray. Then fourth, if you do a synovial fluid analysis, so very important, you will find evidence of WBC count more than 2000 cells per microliter. So that is also very characteristic for an inflammatory joint pain. Unlike a degenerative joint pain like osteoarthritis, you may not find any evidence of WBCs in the synovial fluid, right? So let us put things back into perspective. We are looking at approach to arthritis. So whenever a patient comes to you with joint pains, first you have to know whether this is an articular involvement or an extra-articular involvement. Secondly, you will have to find out clearly whether this is an inflammatory arthritis or not. So when you take the history of the patient, always ask about early morning stiffness lasting for more than 35 to 45 minutes and whether it increases with rest, and then you'll also have to ask about swelling of the joints, right? So in fact, whenever you look at a rheumatology proforma for looking at your joints or examining the joints, you always do a tender and a swollen joint count. So after you have found out whether this is an inflammatory arthritis, then you have to decide and classify what type of joint involvement is present. Okay, so based on the number of joints that are involved, you can classify this as monoarthritis, oligoarthritis or polyarthritis. So monoarthritis means that there is only one single joint that is involved. Okay, most often this monoarthritis is seen in large joint involvement, like only the ankle joint is involved or like only the knee joint is involved, right? So what are the examples of monoarthritis? Always remember that whenever you look at a monoarthritis, you may not be dealing with only an inflammatory disorder, okay? Always rule out infections. Very important point. So any patient who is presenting with a monoarthritis syndrome where only one joint is swollen, you always have to rule out infections. And how do you rule out that? You have to do a synovial fluid analysis and see for evidence of septic arthritis. Okay? So this is a very important point. So always rule out septic arthritis in a patient who is presenting with monoarthritis, because nowadays with the advent of ultrasound, we can do a lot of other local treatment for the management of arthritis. You can give intra-articular steroid injections, you can give injections within the joint to keep the patient comfortable, right? So before you administer an intra-articular steroid, always rule out a septic arthritis in a patient with monoarthritis. Septic can be due to many reasons. It can be a tubercular joint, it can be bacterial infections, it can be anything, right? So this is monoarthritis. When you think of inflammatory causes for monoarthritis, you can think of peripheral spondyloarthropathies like your reactive arthritis or your IBD associated arthritis. Then you also have to think of crystal arthropathies which can present with monoarthritis like your hyperuricemia, gout or your CPPD related diseases. Then oligoarthritis means what? Oligoarthritis is when 2 to 4 joints are involved. Okay, so what are the causes for oligoarthritis? Rheumatoid arthritis can cause, then Sjogren's can cause oligoarthritis, then you can have rheumatic fever which can cause oligo to polyarthritis, right? You can cause spondyloarthropathies. So there are a lot of causes of oligoarthritis. Polyarthritis is when more than 4 joints are involved, and rheumatoid arthritis is the most characteristic common example for a polyarthritis. Okay, so this is how you should describe our arthritis. So first you find out whether this is an articular involvement or an extra-articular involvement. Then you have to find out whether this is an inflammatory or a non-inflammatory cause. Then you have to find out a number of joints that are involved, mono, oligo or polyarthritis. Then the next part of your examination and history taking when it comes to a patient with arthritis is you have to fit it into a particular time frame, right? So you see whether this is a subacute, acute or a chronic onset of arthritis, right? So acute, you always remember again and again that septic arthritis has to be ruled out. Okay, so whenever a patient presents with acute arthritis. Other causes of acute arthritis, very important, gout. It presents precipitously with a severely inflamed joint. Apart from that, certain forms of RA can present as acute arthritis as well. So certain forms of RA can also present as acute arthritis. When you speak of subacute arthritis, you think of reactive arthritis, which usually presents about 2 to 3 weeks after an infection, right? So that can be a reactive arthritis. Chronic forms, your spondyloarthropathies or your rheumatoid arthritis are examples of chronic forms of arthritis. Okay, and even your chronic tophaceous gout. So gout can present as acute, gout can present as chronic as well. Chronic tophaceous gout usually presents as a polyarticular involvement. Clear? So this is about how you will fit your arthritis into the time frame. Now let us look at the consolidated approach to how will you approach a patient with arthritis. Right? So first you will have to decide based on the location. Right? Now that you have decided that this is an inflammatory arthritis, there is evidence of articular involvement, you find out the location and then fit it onto the time frame. So this can be axial or it can be a peripheral involvement. If there is axial involvement, you think of axial spondyloarthropathies, including your ankylosing spondylosis. If there is a predominant peripheral involvement, then you see if this is a mono, oligo or polyarthritis. In a monoarthritis, like I told you, always the first step will be to rule out a septic arthritis. And how do you do that? By doing a synovial fluid analysis. Okay, very important point. In a septic arthritis, you will have neutrophilic inflammation. You will have neutrophilic inflammation and the counts will be in lakhs. Okay, it's not more than 2000 that you see in inflammatory arthritis. Here the counts will be in lakhs and the gram stain may be positive, culture may be positive for the organism, or if you send a gene expert, if you do a biofire on the sample, you may find evidence of infections. Then in inflammatory arthritis, what will you find? You will find lymphocytic predominance unless there is an overlying infection. Okay, then when you speak about polyarthritis, you also have to speak about the pattern, whether it is migratory or additive in nature. So whenever you speak about polyarthritis, speak about whether this is migratory or additive in nature. If this is migratory, that means that one joint is inflamed, then it settles down, then after some time the next joint is involved and the previous joint that was involved usually settles down before the next joint is involved. This is a migratory pattern, most commonly seen where? We have seen this in rheumatic fever. Additive means that, let us say that this is the ankle joint is still inflamed, and when it is inflamed there can be a new knee joint involvement as well, and this is seen in reactive arthritis. Okay, so this is about the pattern of involvement in polyarthritis. Also another important point that you have to discuss when you speak about this arthritis is whether this is symmetrical or asymmetrical, right? So if there is a bilateral symmetrical involvement, where is it seen? It is seen in rheumatoid arthritis. But if there is an asymmetrical involvement, what will you consider? You will consider a reactive arthritis or a peripheral spondyloarthropathy. Okay, so this is about the various features that you have to consider whenever you approach a patient with arthritis. Then lastly but not the least, you have to see the pattern of joint involvement. So one thing about rheumatology is that there are diseases which follow a specific pattern. So let me demonstrate that with the help of this osteoarthritis versus rheumatoid arthritis. Okay, so can you see that there is a metacarpophalangeal joint involvement, right? So the first metacarpophalangeal joint involvement can be there, which is a characteristic feature seen in RA, which is not seen in osteoarthritis. Okay, then in osteoarthritis you can characteristically see distal interphalangeal joint involvement. The DIPs are spared in RA, right? So though both osteoarthritis and rheumatoid arthritis can be bilaterally symmetrical, distal interphalangeal joint involvement is seen in osteoarthritis, which is not seen in rheumatoid arthritis. Can you see that the wrist is more common, elbow is more common in rheumatoid arthritis, which is not there in osteoarthritis, right? Then temporomandibular joint involvement is definitely seen in rheumatoid arthritis, which is not there in osteoarthritis, right? Then first carpo-metacarpal joint involvement is there in osteoarthritis, which may or may not be present in rheumatoid arthritis. So that is why the pattern of involvement becomes very, very important when you approach a case of arthritis. Okay, so this is about the approach to arthritis session. So whenever you approach an arthritis, always look at whether this is an articular or a periarticular involvement. Secondly, you see whether this is an inflammatory arthritis or no. If this is an inflammatory arthritis, you try to place it if it is mono, oligo or polyarticular. Then you look at the symmetry, you look at the pattern, and then you can form a differential diagnosis based on that. Alright? Thank you.